Welcome to the Ortho Joke Podcast, a joint production of the Journal of Bone and Joint Surgery and Ortho Evidence. Join hosts Mohit Bhandari and Marc Swankowski as they discuss current topics and publications in the world of orthopedics and beyond.
Okay, well, good morning, Mo.
Good morning.
It looks like you're at home at McMaster in the OrthoPod.
Yeah,
studio.
the little cubby hole that is our podcast room. Yes, I am, planning some big travel. I think I'm out of the country most of October, but yeah, it's good and bad, right? And I think our guest, we'll speak to our guest about travel.
Yeah,
I know he's traveled a bit too. So.
You both are very experienced road warriors, but I'm very pleased to introduce our guest, my good friend Dr. Dan Barry from down the road here on Highway 52 in Minnesota. For those of you who don't know Dr. Barry, I think there's very few of you, but Dan is a native of Oregon and has worked his entire career at Mayo Clinic, led the department, has a P32 grant with the NIH to study the issues surrounding joint registries, has been president of the Academy and AUKUS, was a trustee of the JBJS, and served very effectively there. I will say as the recipient of that outstanding service for a decade. And Dan is a world expert in the area of joint replacement, revision, infection, and robotics. And the reason why I suggested that we ask Dan to come on the program, he's been on the program in the past regarding the efforts of the P32 grant with Dr. Llewellyn. But Dan has been very thoughtful about the robotics, I would say, landslide in arthroplasty. And it seems like everybody's talking about it. And I know OE has done a lot of analytic work on what's been published, and we have in the journal that really has shown minimal long-term benefit of these advanced technologies. But I believe Dan has some, I would say, well thought out, well evidence-based thinking about the future of it. So Dan, take it away.
Well, first of all, Marc and Mo, thanks so much for the opportunity to join you. It's great. Marc, thanks for everything you did for JBJS over the last many decades of your career, but especially the last decade or so as you were the editor-in-chief. And Mo, congratulations on your ascendance to that job. I know you'll be absolutely superb. We couldn't have gotten a better person, so it's fabulous. Thanks for having me with you. Well, you're right. I mean, you've chosen a great topic, robotics. It's an area with incredible promise. And yet, right now, there's starting to come in quite a bit of information and data, which we can discuss, that kind of tells us where we are with it clinically. So you've chosen a great topic, and I'm looking forward to the discussion with you. I'll just make a few comments at the start. Marc, you're right. You've heard me talk on this topic before, and I do think that digital technologies, if you will, robotics being part of that, and probably the biggest part of it right now, have an incredible promise in orthopedics. I mean, we've seen how they've changed everything else in our lives, and there's no reason to think that they can't also, in some ways, change how we practice orthopedics in the operating room. They give us the opportunity for incredible precision, incredible accuracy, which we don't always have with hand instruments, at least for some of the procedures we do. And in addition to that, I think that they also give us the opportunity to, if you will, take surgeries that right now are challenging, difficult, sometimes at least an art form in many cases, hard to learn, takes a long time to learn, and potentially make them more learnable, more translatable to a bigger part of the orthopedic community. So that's the promise. The promise, of course, isn't always exactly where you are at a specific time, but I do think we shouldn't lose sight in our discussions that we're going to have coming up in the next half hour about what the promise is. The promise is real, and I think I'd be surprised if that promise isn't at some point realized in one way or another. The precision and the accuracy business has been shown to be true. Robotics can give you more precise, if you will, bone cuts, more accurate bone cuts, and in hip and knee replacement, those can be important, and same with implant positioning. So they have some benefits, potentially. And as far as surrogate outcomes go, radiographic outcomes in particular, the robotics have been shown to provide better, if you will, surrogate outcomes. That is, how accurately can you put an implant in where you say you're going to put it each and every time, or almost every time. So that part of the promise has sort of been proven to be, I guess, realized. And if I can put it that way, that promise not only has the ability to get rid of outliers, which we know have bad results, but it also has the potential to allow surgeons to fine tune what they do for every patient. So if you will, personalize things in a way we can't do with our hand instruments because we're simply just not that precise. So it's possible that by fine tuning things personally for every patient, we can do a better job in the knee, for example, with how happy patients are and their functional outcomes, into the hip, maybe eliminating certain problems like instability in patients with hip spine problems, that sort of thing. So that's the promise. But Marc, you absolutely rightly brought up the question of, has the promise been realized clinically? And here's the problem. The promise really has not yet been realized clinically. If you look at big series and aggregated literature, what I think we can say fairly faithfully right now is that while robotics have improved some surrogate outcomes, if you look at the clinical outcomes, that is, how happy are patients, how are they doing, is the revision rate better, it's very hard to show any substantial difference between robotics and hand instruments for most of the hip and knee arthroplasty world. I just attended a great meeting, the Knee Society and the European Knee Society, which was held in London a few weeks ago. And Jan Victor is one of the most thoughtful thinkers in this area from Europe. He's from Belgium. Presented a great paper where they did a very detailed and high quality meta-analysis of what's available in the robotic literature. And basically their conclusion was you do better radiographically with the robotic knee replacements, but you can't really show any substantial improvement in outcomes. Some of the papers show at least equivalence, maybe minor differences, but not big enough differences to be notably clinically different. And I think we should ask ourselves the question, like, why would that be? And what I would say is that, first of all, if you think that robotics are going to get rid of outliers, those are going to be kind of hard to pick up in series. There's probably only a few outliers in the hands of good surgeons, so it may be hard to pick those up. We'll have to see when it's translated to the bigger community whether that's true or not. And I guess the second point is that robotics, if they do make a difference, it may be that they make relatively small shades of difference, if you will, in clinical outcomes that we just don't pick up. And so you could argue, are those important or not? We don't know, but those are at least some of the possibilities. The other thing I'll just say is that if you look at big databases where we try to find out how new procedures are doing, it is very difficult to look at new technology because new technology tends to be used in patients who can afford it, by surgeons who are good at it, by surgeons who may be conflicted, and by surgeons who are believers in it. And so the patients are believers, the surgeons are believers, and so the outcomes may reflect those biases. So it's going to be very hard right now to show big differences just because it looks as though the differences are relatively small clinically, even though the potential advantages are, at least for certain patients, kind of great. I'm sorry, I'm speaking too long already.
No, this is, for those listening, they've already gotten a year's worth of information in 5 minutes, which is very typical of anyone who's heard you speak. So a huge thank you for that. Just a quick question for you is around this issue of surrogates. If in fact, that there seems to be an impact on surrogates, but the surrogates don't seem to translate to clinical practice, do you think we have the right surrogates for?
So it's a fabulous question. So, I mean, there's two sort of categories of surrogates that people use. One is the radiographic surrogate. Mm-hmm. So how well did you perform the procedure in terms of how the radiographs look? And that one, it's possible that the surrogates are just going to take longer to be proven or not. So it's possible that you may need 10 or 15 years to show that minor changes in alignment in the knee, for example, translate into improvements. Although so far that was never shown with standard instruments. So I'm a little skeptical about whether it'll be shown with radiographic instruments, but that's one thing. It's possible also that the surrogate radiographically is something we don't pick up with our clinical outcomes. So let me just put it this way. There's a lot of work being done in the knee to try to get rid of the so-called 10 or 20% of patients that are not fully satisfied. Mm-hmm. And right now, it's been hard to show that robotics, even though the promise is that maybe if you personalize it enough, you can get rid of those 10 or 20% of patients. It's possible that we don't have sensitive enough outcome tools to pick up minor differences. You could also argue if you need such sensitive outcome tools, is there really a big enough difference that it really matters? And I think that is definitely subject to debate. So it's an interesting question, Mo. The last category of surrogates that people have tended to use is one that I honestly am pretty critical of, and that is using, if you will, biologic markers to say that this operation was less invasive or less destructive or, should give better outcomes. So you look at some if you will, markers of inflammation. There's quite a few that have been used over the years.
Yep.
And that is the advantage of people doing studies of being able to give you a quick and dirty answer to something, because you get the data, within a few days after surgery, and you can publish it fast. But to my knowledge, those markers have never really been shown to correlate in any way with anything clinically. Everybody did this initially with minimally invasive surgery. Now they're doing it with robotics, saying, oh, the ILXYZ is less, or the CRP is less if you use robotics. Does that really translate into anything important clinically? I frankly am a skeptic on that. And I actually hope that we're careful as we publish things in the future that we don't overdo those kind of studies, because they're easy to do sort of, but I honestly am not so sure that they mean much.
Very interesting.
Yeah. Well, Dan, you have thought perhaps more about this topic than anybody in arthroplasty. I'll grant you that. But so to the real promises for the non-expert surgeon, and you're a lifelong researcher, and you've thought about research methodology way more than most humans. Do you have any possible way that we could get the information on community-based surgeons that are non-academic, non-conflicted, who do less than 50 knees and hips a year? I know you've thought about this. Is there any way possible that we could ever get that kind of data?
It's a great question, Mark. You've hit the nail on the head. I mean, one of the promises of this technology is for the super expert. Maybe you can super customize everything to the patient. The other is for the broad use of in surgeons, and whether you can help surgeons get rid of the outliers, which we know do badly. And they probably are more common among surgeons who don't do the operation as frequently. We know that from big data that shows that people that have lower volumes generally don't have quite such good outcomes as people with higher volumes. So you're right, Mark, to ask the question. The question is, how do you find out whether that's true or not, right? And it's very hard to figure out any sort of prospective randomized trials to do it, just because this kind of question doesn't lend itself to it. So then you get down to a pragmatic question of, can you say what happened with a big group of surgeons who were using old technology, and what happened to the group of surgeons if they start using new technology? And then you might start to get at the problem. The question, though, is always, are you looking at just the new technology, or are you looking at all the rest of the changes in practice that come over time? And so trying to prove that one technology is the critical factor when a lot of things have changed is always a little difficult. That is where maybe a surrogate technology or endpoint can be helpful. You might take a big group of surgeons who don't do as many surgeries, look at all their x-rays before they started doing it with robotics, look at after they started doing it, and say, okay, were there 10% of patients who were bad enough outliers that we really think they might do poorly over time? That might be as close as we get, and I'll grant you that's not perfect.
Yeah.
How much pressure, Dan, like knowing how much the word robotic surgery specifically and robotic joint surgery is in sort of the language of every patient who's considering a total joint replacement, how much pressure is there now on a newly graduated joint surgeon who may be heading into the community to say, I have no choice but to adopt this, whether I believe the evidence or not? It is a bit, of this futures, as you've been talking. How much pressure has I would say the word marketing of this and patient-driven part of this?
You've asked another fabulous question, Mo, and I think the answer is, in the United States at least, almost all young surgeons are going to be trained in robotics for two reasons. One, because most of the training programs have people at them that are interested in robotics, are trying to figure them out and are interested in using this new tool. So the training is going to be on robotics. That's just a fact. It's a practical fact, whether you think they're better or not. And the second point is the one you bring up, and that is that from the standpoint of a surgeon going out into practice, particularly if you're trying to make your way in practice as a new surgeon, there's tremendous pressure to use new technologies that patients press for. And it's quite interesting to look at where robotics have been adopted around the world, most notably. And they've, generally speaking, been adopted in situations where you have a country that's wealthy enough to pay for them. You need that, of course. And many Western countries are, but not all. And there are also pockets, by the way, in countries that aren't so wealthy that have wealthy people where they've been adopted heavily. And then there also tend to be in countries where there's a entrepreneurial flair to the medicine, if I can put it that way, where there are people that are out there, if you will, marketing their wares to patients, and patients latch on to new technologies in general, to be quite honest with you, robotics being one of them. So you've asked a great question.
Well, I've just got one more for you, Dan, and then I'll let Mo have the last word, if you will. I actually am in agreement with you fully that it is going to be the future to reduce the outliers. And so I envision a future when young surgeons are trained in these centers and they're not going to have enough experience to deal with it if the robot goes down in the middle of a procedure. And how would you envision? Do you envision a future where there's always a backup robot in all ORs or two? How are we going to deal with this?
You couldn't have asked a better question, Mark. It's a thing that's, I think, on every person's mind who does any sort of education. And we all remember what happened with the 737 MAX Boeing catastrophe. And basically, it hinged around the fact that pilots were given a new technology that they sort of understood and didn't completely understand. And they may not have really understood the bailouts to the technology too well. And we all know that there were some tragedies that came of that. I may be oversimplifying the story from the aeronautics standpoint, but you get the point. From the standpoint of surgeons learning the technique, I think there's going to be a whole generation of surgeons who basically only know how to use robotics.
Yeah.
I would love to say that they will be dual trained. They'll know how to use robotics and they'll know how to use hand instruments. But the facts are that's not actually happening. We have many people apply to our fellowship now who have not seen a knee instrumented with hand instruments. So they don't know how to bail out. So my answer is, we are going to have to figure out ways with the new technologies to provide a new technology bailout to the new technology, because it's not going to be hand instrument bailout to the new technology in the future. I just don't see that as what's going to happen. So we're in the betwixt and between era, Mark, and I think it's a little bit of a dangerous era, honestly. I was at the Hip Society meeting, closed Hip Society meeting a week ago, and I was moderating a session on robotics, and I asked all the experts on the panel, who were all robotic surgeons, have you ever had a time where you kind of blindly put the reamer in the acetabulum, relied on the robot to ream it right? You can't really see what's going on because you got a tiny incision, and you pulled the reamer out and the hole was not quite what you had planned and you had a big problem. And they all kind of, smirked and didn't say anything. And the audience laughed. And so afterwards, I walked to the back of the room and a surgeon came up to me and said, Dan, I didn't want to say it, but that's exactly what happened to me one time. The robotic array had gotten loose. The thing wasn't where things were planned, and it was a big deal. So he was an experienced surgeon. He knew how to get out of the weeds, but that would not necessarily happen for everybody. So you've asked a fabulous question, Mark. We're in this dangerous era where people have got the new technology. They're losing the old technology, but we don't have fixes for the new technology with the new technology yet. At least I don't think so.
Yeah. And as we finish off, Dan, I'm going to, if I could, right now, more than ever, we need to find ways to be creative, right? With AI and all these sorts of things. Yeah. When you look back, and I'm going to try to personalize this, I think there's got to be a lot of people have the same question I do. And maybe you've already articulated this to others, but I've never heard you say it specifically to us. So I'm going to take the liberty of asking, which is...
You're kind of scaring me, Mo. I don't know what you're
doing. No, but how have you stayed? What's been your secret in life, whether it's a weekly schedule, a daily ritual, whatever it is, to be able to stay creative? Getting good ideas is, really, really hard. And again, executing beautifully a trial on a bad idea never leads to a good outcome anyway. So how have you done that? If you're giving advice to everyone else, who's been trying to figure this out, especially now, as we look to the future, are there things you've done, focus things you've done, getting away, whatever it may be, that inspires you to have?
To be honest, I think it's the people you're around. So I'm fortunate in my practice at the Mayo Clinic to be around a whole lot of bright partners. We're always kicking around, what's going well, but also showing our problems honestly here and saying, what didn't go well? What are the unsolved problems? And I think trying to find the unsolved problems is always the key. And to some degree, you might argue robotics is not picking on the biggest unsolved problem. It's sort of fine-tuning something we're already pretty good at. So to me, finding the next unsolved problem and trying to work on it and figure out ways to get better at it are good. Infection's one of those right now in joint replacement, no question about it. And I would also say I've been lucky to be able to go to lots of national, international meetings all the time and hear from bright people who approach problems completely differently than we do. So if I go to Europe or Asia, oftentimes their approach is totally different. And sometimes you go, wow, that just seems nuts compared to what I'm used to. And then you go back and chew on it for a little while and you go, you know what? There's a kernel of something interesting there. and it allows you to think about different ways of thinking about problems and identifying problems that you might not think about otherwise. So to me, that's been the thing that's been stimulating, at least one of the things that's been stimulating, Mo.
Well, that's perfectly aligned with the recent paper that just came out, Dan, that said, getting out and traveling actually, just leads to a healthier and happier life, but also leads to better ideas. So I think you just either you read the paper,
I didn't,
or you are right there on top of it. Well, thank you very much. Again, huge thanks for your insight. And I think the area of robotics still is going to have lots and lots of opportunity to advance. But I think we should take it with at least some degree of caution as we look to interpreting the data. So thanks again, and appreciate your time with us. Thanks again too, Marc.
And if I could, just one more thing. I think Dan really did not offer up his real secret, which is fishing. Dan is an expert fisherman, fishes all over the planet. And I think that's where he spends his time thinking about important things and what to do next in his life. So I know you wouldn't say that, and maybe people don't know that about you, but I know that's true.
Well, you're right. It's true. But what I would say, if you could make that comment a little generic, is that for all the young surgeons, having some things that you do in your life that are not strictly orthopedics and strictly work is really important. It's important during your career, even when you're really busy, along with all your family stuff. But it's also important at different times later in your life when you need things to stimulate you that aren't not only related to our profession. But having a little time to contemplate things and chew on them is good too, Marc. You're exactly right.
Well, catching a big or beautiful fish. Dan, thanks so much for offering your expertise. You have done so much for joint replacement around the globe, and we're grateful for your service and for your continued research efforts to try to make these procedures even safer for our patients. So thanks, Dan. Dan, thanks for spending the time with us, and thanks for everything you've done.
Marc and Mo, thank you for having me, and a huge thanks to you. The orthopedic community ought to know how much work it is to run an enterprise like JBJS and run it so well. And having that high quality journal as part of our profession is such a big deal. It forces us to do good science. It forces us to think harder. And thank you both very much for the work that goes into that, because it is oftentimes insane numbers of hours behind the scenes. So we're all deeply appreciative of that.
Thanks so much and have a good day. Appreciate your time.
Right. Take care.
Bye-bye.